I tell my daughters all the time, you don't have to be that smart to be a urologist. You need to work really hard.
This is Inside Urology, Cutting to the Chase, a podcast from the Indiana University School of Medicine Department of Urology. We talk about all things urology with Dr. Clint Cary. Each episode features conversations with physicians, researchers, patients, and we'll share some of the stories shaping the field. So let's cut right to the chase. Well, welcome into episode 2, Inside Urology, Cutting to the Chase. I'm your host, Annie, and I'm joined again by Dr. Clint Cary, the current chair of the department. And I think, we need to thank our listeners, Clint, for making it through episode 1 now into episode 2.
That's right.
And we've learned a couple things along the way.
Yes. Thanks for having me back after the first one. I appreciate that. Yes, we learned that I don't need to move around as much when we're talking. It seems like the sound of my voice was soft sometimes and very loud at others. And so I'm going to try to stay right in on the microphone today.
Right. And for me, just, don't let the SD card fall behind your desk. And
That's right. We almost had to shoot episode 1 completely again.
Yeah. So thanks for tuning in to episode 2. But we are very excited today for our guest. A lot of people know him in the department, outside of the department, all around. Dr. Michael Koch, thank you so much for joining us today. And we're looking forward to talking to you.
Thanks for thinking of having me here. I'm excited to see how this goes.
And this is the first time I've met you, but Clint, I'm sure you've
Absolutely.
Yeah.
Yes, absolutely. I've known Mike for quite a while, and he's had a big influence on my career and my time here at IU. And so this is episode 2. I'm sure it's Mike's first podcast episode, so I'm sure he's excited about it.
It is definitely my first podcast, yeah.
Well, we're excited to have you. Tell us, it was 26 years, right, that you were the chair?
Yes.
That's a long time. So what, you have 25 to go?
Yeah, if we're going for that record, yeah, we got 25 more.
Well, yeah, that's a long stint. But take us back to when you were first became chair. What was the department like at that time?
Well, it was very well regarded nationally. It was the reputation of IU at that time was based upon mostly 2 things. So it was outstanding pediatric urology that had been kind of built by Dr. Rink, who's still here, and Dr. Mitchell, who was a pretty famous pediatric urologist at the time. And then probably even more so by the testis cancer program, which was largely Dr. Donahue, and his mentees were Dr. Foster and Dr. Burrell. It was very focused on those 2 areas, which I think was one of the problems with the department as well at the time. Just to give you a frame of reference in terms of what I was doing at the time, I was roughly Clint's age, in my early 40s. I don't actually know exactly how old you are.
I made it into the mid-40 range at this point.
Anyway, I was very happy where I was, but I wanted to assume kind of a leadership position. And I looked at a number of different jobs around the country, and of the ones that I was offered, IU was the most prestigious place, and I felt like it was something that could be very proud of having a leadership role. I did not really know all the problems that existed in the department when I signed to come, and I learned those things fairly quickly.
Clint, you have any?
Yeah, we could diverge down that quite a bit, but we will. Let's move on. So you talked about the things that they were recognized for, but what were some of the things that you immediately recognized were some of the biggest opportunities here for the department?
Okay, so let me. I didn't fully paint the picture, let me add a little bit to what I just said. So Dr. Mitchell was the sort of famous pediatric urologist. He left 9 years before I came, and then Dr. Donahue was the very internationally known in testis cancer, and he left 2 years before I came. And so the people that kind of made IU famous were no longer here. And Dr. Donahue, I think, maybe in an effort to help me assume a leadership role, or whatever person took the chair job, decided to get out of that person's hair and just let them fend for themselves. In retrospect, it would have been helpful to have him around for some of the issues, but he didn't think that was a good move at the time. So the department was very small. So there were 7 people in the department, 2 pediatric and 5 adult. So I was the 8th person. If you compare it to today, we're mid-30s in terms of the number of faculty, and we had no nurse practitioners and so on. And so we're a pretty small department, although all departments were a little bit smaller at that time. The things that struck me as problematic with the department, though, is there was quite a bit of acrimony amongst the department members at the time. And the department had been without a chair for 4 years, and they'd kind of grown to like it that way. So having somebody new come in wasn't immediately embraced as a good thing. The other things I would say that are drastically different than now is there was no really subspecialization other than pediatric urology in the department. Everybody did everything. Actually, and the number one procedure in the department was a rich peritoneal lymph node dissection. Those were done by the person that was trained in female urology. And so that was the most common procedure. We didn't do prostates. We didn't do a lot of urethral stricture disease. There was almost no stone disease done in the department at the time, and not a lot of benign prostate enlargement. So in terms of what was in the true academic department at the time, it was not a broad-based department. And actually, both in terms of reputation, but also in terms of just being competitive for patient care in the city and in the central Indiana, that's really problematic. So the biggest issues were the sort of faculty not getting along, and then the not being a very broad thing. The third thing I recognized I didn't realize this till I got here, is we were not treating residents, and even more so, we were not treating students very well. I was here roughly a month when the med school sent me a memo that said urology was no longer part of the med school education. And I really had to scramble to do that. And the residency hadn't been well looked at either. We're much healthier today than we were then.
So with all those, you highlighted the things that we were well known for, but obviously some areas that needed some growth and improvement. How did you think about chipping away at that? Were there certain things where I was going to build this program or do that, or was it more about these are the people that I want to hire? How did you think about trying to improve upon things?
Well, the first thing was for what I would do personally. So that was the first. And basically, the reason I've become the prostate cancer person, if you believe that, is nobody was doing it. There was 30 prostatectomies a year done at the only university in only med school in Indiana. And I'm like, okay, well, I've done a lot of that before. I'll be the one that does that. Initially, I was doing 20 or so RPLDs a year, and I've always liked doing cystectomies. So all I did was cystectomies and prostates, and then I was looking for ways to grow that. I also recognized that everybody, with the exception of Dr. Burrell at the time, had done some component of their training at IU. And so we were very inbred. We needed people that had other ideas from other places. So Gardner was the first one I trained. He was trained at Cornell and very well trained. Because he wasn't part of the inner group and hadn't trained at IU, that was a battle for him when he first started. And we just slowly, I didn't really have like a full-blown plan. I was thinking about that with some of the questions I thought I might get asked. I don't view myself as a visionary person. I'm sort of react to what the immediate needs are, and I'm kind
Problem solver.
And I'm kind of a incrementalist. I make small changes and let it grow. I find people accept that better, and it can grow in that way. So I didn't have an agenda where I was going to hire one stone guy, one infertility person, one person for this and that. I did it as the opportunities and the needs kind of arose.
Yeah. And then,
I was just going to say, how did you balance like all the faculty, someone coming in from not having a chair, and just kind of balance all of that?
There was a lot of bad days in the first few years. There's not one answer to that question. You just have to persevere. I tried to work really hard. I tried to act like I think everybody else should behave. I tried to treat everybody respectfully. I didn't always succeed. And I hope that some people would model what I thought was good behavior. Some people do, some people don't. Some people need a more aggressive approach to get them to fit with your vision of things.
So in, our department now, a lot of your leadership over the last 26 years, we do a lot of things across the medical school, whether it's education of residents and students and research now. But back then, how did you prioritize? You were maybe hiring new people or trying to change the culture and maybe create some subspecializations. But did you have much focus or thought about we need to build our research portfolio or things that, we think about today, and we certainly get judged on Blue Ridge rankings and things like that? Was that much of a thought back then?
Yes, but things were very different then than now. So to paint a full picture, all these surgical departments within the med school were their own private corporations at the time, and the urology corporation, like some of the other ones, were owned by the members of the corporation. We have always had very, very little support financially from the school, and I didn't have a package like chairs get nowadays to invest in research. I did have one gift, and that was the Thompson Chair for Prostate Cancer Research, and that was something that was given to the school in general, but they assigned that to urology as part of my startup package. So I hired a fellow at the time who I was excited about. He had a relationship with Dr. Gardner as well. His name was Koch, and the timing was bad. He had developed and cloned a gene that was active in prostate cancer, and he had a methodology to use viruses to infect prostate cancer cells with it. And there was a national catastrophe at the University of Pennsylvania at the time, and the NIH shut down all gene therapy research for years, within months of when I had hired this individual. And while he was a great guy, he ended up being a bit of a bust for the department in terms of research productivity. Yeah. But we stuck with him for a long time with that resources because it wasn't really his fault.
Sure.
But when he didn't get renewed, he had to make a break at some point and go into some other related type of research in prostate cancer, but he was never able to do that. So eventually we let him go, and that's ultimately how we've supported Dr. Al-Kanawi that we have now, and I think she's going to be very successful personally. She was the last hire I had, I think.
Yeah, from a research perspective,
Yeah.
for sure. So we've covered a little bit of kind of the landscape when you got here, and some things, and maybe not initiatives, but just directions that you wanted to go. Is there, thinking back, and it may be a hard question to answer, but thinking back, was there one particular time when you felt the trajectory was changing into how you wanted it to be, or one particular hire or recruit, or a few different people that came on board, or?
No, it was what I did realize over time is that the most important thing in a hire is excuse me, sort of the personal qualities of the person. So you need a person that has your values, your work ethic, your sort of sense of community, and somebody that you will enjoy working with and will enjoy working with you, which means they'll enjoy working with others that also have that you've hired in that same way. That's the number one attribute. It's not surgical ability. It's not how smart they are in urology. I tell my daughters all the time, you don't have to be that smart to be a urologist. You need to work really hard. So you need those sort of intrinsic qualities. If you have that, most of those people are going to be successful. And then same thing that we do when we choose residents. You need people that are going to support each other and have that good work ethic. And then you need to model it yourself, and then people are going to kind of believe in it. It's going to become the way it is. I don't think it was... some of the people were pretty supportive of residents. We certainly didn't have a sense of community and feeling like we're all working towards the same goal. We didn't have that for quite a while. And it took some people leaving, and it took some difficult meetings to get to that.
What were some of your best moments or favorite moments?
Well, I would say just seeing not just one thing, but there's many of our faculty have gone on to be recognized within their respective subspecialties and for their contributions, taking leadership roles around the country, and those are the best moments. Seeing other people succeed, and it all ties back to being from a great place. So we have many people in different honorary societies that have contributed in big ways to the field. I do think there wasn't a sense when I first started that it was a valuable thing to contribute to the administrative part of urology nationally, to be on national boards, to be on there's a board of urology that oversees the quality of urology. There's the AUA, which is the board that represents urology kind of academically, represents the government. There's different pediatric societies. There's been many honorary degrees for different people in the department. That's all. You feel like you're a little bit part of that if you've supported those people. They've done it themselves, but you've kind of created the atmosphere where they can achieve things, and they seem to think it's valuable to do it now, not something because the reason in the past I think people didn't think it was as valuable is those are all paid, those are all volunteer things, and originally this sort of ethos of the department was too tied to finances and not enough tied to contributions. The other thing I would say in terms of what I think we do better at now, we could always do better, is being academic urologists, and by that I mean contributing to the publications in the field. We do fantastic at looking at new techniques and developing new techniques and bringing them to patient care. We don't do great at writing about it and showing everybody how much we can do. And I think we could do a lot. I still think we could do a lot better at that.
Yeah, some of the things that several of you guys were involved with early on was HIFU, and I think probably under-recognized what role Indiana University played in that.
Yeah, it's beyond. I mean, even before me, though, the group, like Indiana Pouches, that was something Burl and Roland and Mike Mitchell did. That was an advance in the field. There was all the stuff in germ cell disease. There was the augmentation procedures in bladder. There was Lingaman doing lithotripsy, then percutaneous stone disease. We were in HOLEPs. Those are things where we were consistently first in the country. And you can look at great institutions around the country, like a Hopkins or something. They're kind of known for prostatectomy was their thing. Cleveland Clinic was partial nephrectomy. We were many, many different fields, and people are always innovative in the different things they've done. Spiral Montes and pediatric urology, different I don't call it that anymore. Disorders of sexual differentiation procedures. But our guys were they looked at new opportunities. They developed them further, and that's been part of the reputation. And we're known as great quality surgeons around the country.
What is it like, when you first started thinking of the department now? What do you think of just how it's changed and where we are today?
Well, I don't think it's that important, but the numbers of us are much greater. But our abilities and our different people in different expertise areas within urology is much, much better than it was. It's not as it can be more developed than it is now. We even have a pocket of people within the department that just do general urology, more like a private practice would. That's great for resident training, and that should be almost a subspecialty of its own. Somebody that actually does everything. But now we have people that do all the urethral stricture disease, or all the penile implants, or many areas like that. And we tend to train each other. So that's another thing that makes the department much secure than it used to be. There's not, if one guy, if I kick the bucket, there's 5 people that can do what I do. So we're not at any threat. We did have that problem for a while. We had, at one point, a good example is Dr. Mulcahy was one of the first faculty that I joined, and he was very well known around the country for penile implant surgery. And when he told us he was retiring, we had no plan to replace him, and we scrambled for a while, and we've maintained it, and now we're more secure now than we were then. But we don't really have those threats anymore, including a chair. If a chair retires, there's other people that can step into that role now because many people have leadership ability.
So with the benefit of hindsight behind you now, you talked about a lot of things that have changed since you got here. Is there anything that you would do differently knowing what you know now?
Some, yeah, but some of it I think is just a kind of weakness of age and lack of maturity when I first started. I mean, again, I've been down in residency 10 or 12 years when I started. So, and actually my chair that I left at Vanderbilt when I came here, he told me I would have problems with this, is that you want to be liked by a person. I like people to like me. That's what he told me. First thing he says, you need to get over that. And it's not that you shouldn't be liked. It's that being liked is not as important as doing the right thing, and kind of one of the problems, if you want to be liked, you can make the mistake of rewarding people that complain a lot. You can make a mistake of rewarding bad behavior to get them to like you, and that never will fix the problem. They'll just, if you reward them for bad behavior, they just do more bad behavior. Yeah. So you need to get to the point where you say you need to learn to express these are my standards. This is the way this is going to need to work. And occasionally you need to do the opposite of rewarding people. You need to, however you decide to do that, you can just say, that's it. That you've crossed my line, and this is the way this is going to work from now on. So I can tell you I've not fired a lot of people. I've frustrated the heck out of a couple of people until they left. That's one tactic you can do. And there's one that I fired. And I can tell you, it sounds bad, but it's a very healthy thing for you to point out to everybody else, this person has crossed the line and I'm not tolerating that anymore. That took me a good 10 years to do that. But that's an important thing if it's appropriate to be able to do that. And it's hard. If you want everybody to like you, it's hard to get to that.
Is there anything else you learned as a leader throughout your time? I know you just touched on some of it, but anything else? Yeah,
I'll tell you, I started. I don't know how I got picked for this, but the American Urologic Association started a course that was to teach chairs how to be chairs, and basically the way that course, and I ran the course for years. I don't know why they picked me, you would meet with other chairs and talk about how you would make up problems. They were all fictitious, but you'd make up a scenario and ask people in the audience, how would you deal with this? That was very, very educational to me because was frequently not how I would deal with it. And actually, they then had the same program for program directors as well. So all institutions are different, and they all have different resources. And the things I learned from that was that I should rely on other people in similar roles, other chairs, particularly experienced chairs that have some knowledge of how to deal with difficult situations. And I also learned that you need to rely on your institutions. Now, I would say the last thing you want is the dean to know about everything bad that's going on in your department. You want him to think you're the only department that's really humming. So you don't want to be running to him every time something hits the fan.
Yeah.
But the institutions in difficult situations have people with lots of expertise in things from sexual harassment to DEI issues, whatever it is. They have lots of expertise, and they have lots of attorneys as well if it gets to that point. And you should use your institutions. You got to be careful about what you take to them, because again, sometimes if you can deal with it yourself and it's smooth, that's fine. But when you're over your head, they're there to back you up, and you need to be using them. So that was an important lesson I learned. And then, for example, the one person that I did terminate, I had attorneys lined up well behind me. There was a couple instances like that, and I never went into any of those things thinking I wasn't going to win that situation. And you need the dean. There was one situation where I knew what would happen with a faculty member if I did what I planned to do, and that was they were going to go to the dean. So knowing that, I went and I said, "Hey, this is likely to happen." And when that faculty member did go to the dean said, "I'm with Koch. You need to get out." So those were important lessons that I learned.
Yeah, those are. I've got my notebook over here. I'm taking some notes. That stuff, a lot of the stuff you've already told me, but it's always good to hear again. It's kind of a grandiose question, but when you look back at your time as chair, what do you think? What do you hope people say that you built?
Great department. People that like working with each other, love working with each other, support each other. It's a place they want to work. I mean, I don't need to be, you know me. I don't want a retirement party with 5,000 people there, and I don't want to be people that'll say what a great. I don't need that. I don't need it for me personally. I know what I did. It's not important to me.
Yeah. I knew that. I figured I would ask the question anyway.
What advice, I'm looking at Clint, what advice would you give someone stepping into a department chair role for the first time?
You just gave some of it.
Yeah, I mean, have a mentor.
Yeah.
Rely on your institution. I mean, I hope Clint thinks he's got a department where people like each other, they support each other. It can unravel quickly when stuff gets difficult. So you need to be real attentive to the sort of behind the scenes stuff that's going on. Yeah. Usually somebody will tell you. I'm sure you got a few confidants out there. And then model, and the one thing you can't do is you can't expect a certain behavior of everybody else and not model that yourself. So you need to show that I can work as hard. They realize you can't do as many cases and stuff because you have other things you have to do with your time. That's the only advice I would say. But I would say, someone was asking me this the other day. I mean, I would pick going into medicine all over again because, and I would tell my kids, don't go into medicine to get rich. That time is gone. You go into medicine, you go into business if you want to get rich. That's where money is. But on the other hand, like I said, I'd pick medicine as a career all over again because on a daily basis, people are appreciative for what you do for them, and I don't think you'd get that same kind of feedback if you were selling something to somebody. I just don't think it works the same way. So, and I think here, and I think even tertiary care medicine, like we practice here, is even better because not only are you thanked by your patients, but the patients come to you realizing that, and I think this is true, that, for instance, Dr. Cary can take her that tests cancer that other people cannot do. Other people in his field who are fully trained like he is can't do what he's done, or you're doing something better than other people can do it because that's all you do all the time and you've gotten really good at something. So I think that makes you feel good and feel like you've contributed to society. That part's been important to me. Makes me, I've got the same ego everybody else, or at least all the rest of us have. So it's nice to get a pat on the back once in a while. So that part's nice, but there's not one. There's been a few patients that are. There's an endowed chair that Dr. Cary holds. That was a a generous patient of mine that gave that money. Those things are really nice.
Anything else you want listeners to know that we didn't ask that's top of mind?
My favorite quote is, your relatives don't have to be really smart.
Maybe we'll tease that.
Oh, good.
I was at, I forgot where I was, where it first occurred to me. But I was watching, I'm blanking on the name of the movie.
Step Brothers.
No, that's a good guess. So I love talking about any Will Ferrell movie, but this was the one with Reese Witherspoon where she goes to Harvard.
Oh, Legally Blonde.
Yeah,
Legally
Legally
Blonde.
Blonde.
I don't know.
My favorite
It's like
line-
one of
I
my
don't know why I-
favorites.
So
I
my
don't know
favorite
why I
line in
knew
that movie is when she sees Werner, right?
Uh-huh.
She's Werner in the hall, and he goes, "What are you doing here?" And she says, I go here," and he says, "To Harvard?" And she goes, "Harvard? Like it's hard."
Like it's hard.
That's what I thought. Like it's urology, like it's hard.
Thank you so much. But we do have some fun questions we want to ask. Do you want to ask these today or?
Yeah, we'll maybe do 3. What do
3?
you think?
Okay. We'll do the top 3.
We're going to try to have a segment at the end of all these interviews where we ask maybe not the exact same 3 questions, but 3 questions to everybody. It's a little bit less formal and
These are like favorite movie or something like
yeah, something fun. Yeah.
that. I already told you.
Okay. Your best skill that's like non-medical that you're like weirdly good at.
Wish I could say golf.
You did get a hole-in-one in golf. That's pretty impressive.
Well,
Hey,
that was luck. I have no skills. What would you say?
I have no idea. You
I
mean for
can't
myself?
sing.
or
I
for
can't
you?
sing. I'm totally tone deaf. I can't play a musical instrument. I'm really good at having surgeries. I'm a remarkable healer.
You're
I'm a
starting
remarkable healer.
You're starting to stack those up.
I'm stacking them up. I'm like, I had my back operated on a month ago. And I'm back at work in 2 weeks. And,
Oh, wow.
and you can't tell my wife, but I was swinging a golf club in the basement very shortly. I don't know. I don't really know.
Okay.
We
Not a
got some
answer.
good things in there.
Yeah.
All right. Well, you talked a little bit about movies. What's your favorite movie or current show?
Current show. So ever since COVID, my wife and I we just stream stuff all the time. We don't actually watch regular TV. But we love these series that go on for 3-4 seasons. So right now it's Landman. Landman is pretty awesome
Very
show.
good.
They're only in season 2. But we've liked all of them, whether it's, Yellowstone, Landman, Ozarks, whatever. We're the ones that have a long story. We really enjoyed that. The favorite movie, though, favorite comedy is. So my wife is better at this than me, but I do rely on quotes from movies quite a bit. So my favorite movies that I will quote a lot are Step Brothers, or rarely Dumb and Dumber, Step Brothers, or Talladega Nights. It's got quite a few good,
That's a good one.
quotable quotes in it. So I will use those in the OR. My favorite Step Brothers quote is Will Ferrell says, "This is," when he tells him he can't have TV for a week, his response is, "This is from the planet bullshit." And actually, there's another line, which I'm not going to repeat after that, but I like that line. So if somebody hits a terrible tee shot playing golf, I'll tell them that's from the planet bullshit, whatever that means. So I enjoy that. And then favorite non-comedy, I like sci-fi. So I'd probably say the original Matrix movie. I like that movie a lot.
That's a good one.
Okay. Was that 3 or are we on to another one?
We got one more.
Okay.
Maybe we'll do the last one you added on there.
Yeah. Best advice you've received, or maybe is there a quote that you come back to?
Not that urologists are dumb.
Fair quote, no. Best advice for life?
Yeah.
In
Or
general.
just, yeah.
Whatever.
I'd just say take care of family first.
Yeah.
It's a good one.
All right. Well, Mike, you've made it through your first podcast successfully. Don't worry, we can heavily edit as needed. And we really appreciate you coming on.
Sure.
We are going to see where this thing goes. Hopefully this continues to grow listeners over time. And really appreciated hearing your perspective and your kind of thoughts about the department way back in the day and how you shaped it to today, and have passed it off to me. And I hopefully will handle it with care and keep it going.
Thanks for joining us on this episode of Inside Urology. Make sure to follow, subscribe, and share this episode with someone who might like an inside look at the world of urology. And stay tuned as we keep cutting to the chase.